Call this meeting to order. Who is on the webcast?
Commissioner Khan.
Okay. Anyone else? All right, we have a quorum. Agenda item number 1, approval of minutes. Included in your packet are copies of the minutes from the June 18th public meeting of the Commission. If there are no changes or corrections, I'll entertain a motion for approval.
So moved.
Okay. Any discussion? All in favor? Aye. Any opposed? Minutes are approved. Commissioners, you've received the written updates from the centers. Ben, do you or any center directors have anything you'd like to add?
Thank you, Mr. Chairman. We deferred this last month because the employee was not out, and actually she's not here today. But I wanted no further time to elapse to recognize her. Valerie Aguale, a MHCC staff person working in Linda Barnitzka's center on web development, was given a DHMH Health Secretary's Service Award in April, and this is a pretty special commendation from the department. Valerie got it for her work in converting our website from what it had been based in as a SharePoint application. We had reluctantly converted to SharePoint, and actually Valerie was key in that endeavor. After trying for 2 years to make it work, we elected to go back to a more standard infrastructure. And Valerie did the bulk of the work in that conversion. And Leslie Lebrecht, who I think is here in absentia, will ask her to stand. She is not here either. She's working on Tableau, which more of that to come. But under Leslie's direction, Valerie did a tremendous job, got it up on schedule, and I think you've seen the results of that. The second, as most of you know who attend commission meetings regularly, know that in August we don't hold a commission meeting. Our work groups will be continuing. Of special note, I think, is our work on self-referral will continue. A meeting will be held later this month, and another meeting in August. We will also have a work group meeting on our freestanding medical facility health plan chapter in August, and we'll also continue our work on our payer and consumer pricing portals, which we have already gotten underway. Our work on health IT will also continue, and our health policy board is now nearly at a stage where the next version of HIE regulations are complete, and we would expect those to be coming before the commission in later in the fall. So work groups continue. The commission meeting itself will continue in September with a 1-month hiatus.
Center directors.
Chairman, Commissioners, I would like to invite Angela Vatt to come up to introduce a new member of staff to you all.
Thank you. I'd like to introduce Jake Rawlings to the Commission. Jake is working as a Health Policy Analyst Advanced within the Health Information Exchange Division. Jake comes to us from the U.S. Army Public Health Command, where he worked for 3 years as a program evaluator. During his time at the Public Health Command, Jake evaluated Army-wide health program promotion programs. Prior to his experience at the U.S. Army Public Health Command, Jake worked for Cigna Behavioral Health, where he was a senior care associate performing analysis-related tasks. Jake holds a Master of Science in Psychology and is a native of Pennsylvania. Jake relocated to Baltimore about 5 years ago and has been with the Commission for about 3 weeks. Please join me in welcoming Jake.
Welcome. Any other updates?
I actually forgot to mention that the hospital staff under the quality measures under the Quality Measurement Reporting Center, also received an award. They got the Team Innovation Award from the department for the new website, the Quality Measures Data Center website. And I'm glad you mentioned that because I forgot to acknowledge the hospital team, Eileen Weatherspoon, Miriam Rahman, Evanson Makura, and I don't know if they're here, and Kendall Cody. So Eileen is here representing the group.
The rest of them are coding.
Right.
Any additional updates? All right, let's move to agenda item number 3, results of the analysis of payment for professional services. Srinivas Radara, Chief of Cost and Quality Analysis, and Jin Zhang, Senior Health Policy Analyst, will present the highlights of the mandated report on payment for professional services in Maryland for 2013. And they will also outline new reporting and data dissemination strategies for the medical care database.
Thank you, Mr. Chairman, Commissioners. As you may know, we do this report annually. It's a legislatively mandated report that MHCC is required to report on payment for professional services in Maryland. It's been had a long history and has been more complicated and more detailed in the past, but it has evolved into more of a monitoring report and has high-level analyses now only. We expect that this will continue to evolve as there are new payment models, and we hope to make it more of a web-based report in the future. Today we're going to be discussing the results from the 2013 data analyses, and there are a couple of new items that I just want to highlight, or changes, let's say. One is, as you may know, due to the Medicaid primary care parity rule, there are some fee schedule changes for Medicaid, so our comparisons with Medicaid, we'll talk about that in particular to highlight how that's changed the comparison to private insurance. And the other item is we've taken an interest in sort of the network participation and out-of-network payment. So that we're actually not talking about today. We want to engage carriers in that conversation a little more before we come back to you. So we're going to focus on in-network results for the most part. And then finally, once we present those results, just want to give you a sort of overview of some of the price transparency initiatives that are on the way, just from expanding on these activities. So as I mentioned, there was the original report had two main components. One sort of looked at expenditures and service utilization. That has now been spun off into what's called the privately insured report for us, and that we've presented to you recently. So today we're doing the second part, which is doing normalized prices. We do it based on Medicare's relative value unit. We normalize it to that so you have a standard to compare different payments. So today that's going to be the focus for us. And so Jin Zhang is a new health policy analyst, I guess not so new anymore. She's been here almost 6 months, and this has really been a tremendous activity. I want to point out how much work she's really done, because she took on what was done by a contractor in the past by a team of folks and sort of single-handedly worked them to do this. So really a commendable effort to get this done. Go ahead, Jim.
Thank you, Commissioners. Today I'm going to present the professional service report using MCDB data 2013 for the private insurance services, and to easy comparison, we simulated the Medicaid and the Medicare payment by using Medicaid and Medicare fee schedule for the private insurance services. And we are focusing on comparing the the payment per RVU, which is per relative unit, value unit, which is a standardized, normalized payment that Medicare used to reimburse physicians. So our results indicate that overall the private insurance payments rate kind of remain in a stable way compared with last year, and on average, large payers paid less than our other payers, and in-network payments slightly increased between 2012 to 2013. And when we compared with private insurance payment with Medicaid and Medicare, we found that private rates are on average slightly lower than Medicare payments, but higher than Medicaid payment rates. But I want to let you know that this comparison between private insurance rate and Medicaid is pretty much different from what we found for last year. I'm going to describe more in later slides. And as you can see that on slide number 11, you will see that on average, the private insurance payment rate does not change between 2012 to 2013, even though it's slightly lower, but the difference is so small, it's not efficient to predict any trend in the private insurance rate. And also, you will find that large payers pay less than other payers. That's because large payers have larger, wider networks, so that they are more likely to negotiate with doctors, are more likely to get lower payment, lower rate than other payers. And as you can see, that this pattern is kind of pretty consistent between 2012 and 2013. And on slide number 12, we present the in-network payment rates by market share between 2012 and 2013. And you will see that the overall the overall network payment rates is pretty much close to what we found on last slide, which indicates all services, including both in-network and out-network. That's because in-network services account for over 96% of services, even though out-network payments are pretty much higher than in-network, but they won't change the overall private insurance rate. So, and you will see, you will also see that large payers pay less than other payers. And when we compare the private insurance rate to Medicare, you will see that the rate is slightly lower for private insurance rate, but we compared with previous year's report, we would say that the private insurance rate and the Medicare rate are roughly equivalent. And in terms of the Medicaid fee schedule, historically Medicaid payments are pretty much lower than private insurance rate, but according to the Medicaid primary care parity rule in the ACA, it requires states to pay for primary care evaluation and management services at the same level as Medicare, with the federal government paying the cost increase. Because of that, Medicaid implemented the payment increase in 2013, which results in a substantial increase in the payments per RVU for E&M services, which accounts for about half of all RVUs. So you will see the upper graph on slide number 15 is that the between 2013 to 2012, the Medicare payment per RVU changed significantly, and that is largely driven by the payment increase for the E&M service between 2012 and 2013. Accordingly, the private to Medicaid payment ratios decreased from 1.29 in 2012 to 1.08 in 2013. And I want to remind you that since all the Medicare and Medicaid payments presented here are just simulated results, so it is not able to draw any conclusion about the adequacy of the Medicaid payment here.
All the commissioners are clear. The payment differentials are based on the same underlying population. This is the privately insured population, and what we're comparing is if the privately insured had been paid using Medicaid rates, these are the relationships that would occur. We're not actually looking at a Medicaid population. We're saying if we applied the Medicaid payment rates to the privately insured, that's what the in the top graph, what the RVU levels would be, which you can see are somewhat lower than what's being paid in the private sector. And then you can see the ratios below, but the underlying population is the same.
So that's our brief overview of the results from the report. And so, you know, one of the central goals for this for Center for Analysis of Information Systems is to expand on these activities and really start to develop portals to do more price transparency activities, to get more information about healthcare costs and utilization out. And so we have a few overarching efforts that are ongoing that are largely funded by our grants from CSIO. So I'll just highlight them at a high level, and I think in the coming commission meetings you'll get to see some of these live and in action. So the first, which some of you heard about last year, was looking at provider pricing, which is what CMS has done, putting out a data file that was at the provider and procedure code level. We've been working on developing a companion, private insurance companion to that, and presenting that together on our website. So that's actively in development and is expected to be out this fall. So we'll be presenting that to you as well. The next one is looking at the hospital elective surgical procedures. We envision this being on the current hospital quality portal, and so the idea would be to highlight the things where consumers actually may have some decision making around which hospitals to select or whatnot. And so what we do here is pair both the facility and professional services bill and sort of have some ability to compare across hospitals. So that is also ongoing and is a grant deliverable and should be available this fall. And finally, we have a larger initiative over the next year, which will be working to develop data to present to consumers and to providers. Consumers, we envision presenting by episode and information so they can get a sense of the total cost, not just, you know, sort of an individual visit, the compilation of things. So this could be rehab, post-surgery being bundled together, or things like that, so that people get an idea of what it really might cost. And then the provider portal, the idea is to think about what are things that could help in some decision making. So we're likely to focus on, say, labs and testing, imaging, and sort of what are the costs associated with that, so that providers have some information to begin there that might help in making some clinical decision making. So this is, you know, these are sort of 4 overarching programs. We have others that we are planning, all in efforts to leverage the MCDB data to provide healthcare information to the public and to, in general, make the data more transparent and accessible to the community. So thank you.
Thank you. And I see that you're in your efforts at transparency with provider pricing in particular. Can you tell me what you guys are doing to sort of talk about the limitations of the data? Because while there's been this big push for CMS to release data about providers, there's been a lot of sort of problems about how the data is ultimately used and what the sort of underlying intent is for providers, but more importantly, things like services that are billed incident to advanced practitioners, or pass-through pricing for drugs that are bought and billed and things like that have muddied that water quite substantially, to the point where, headlines for doctors who are earning $21 million off Medicare, and that's the gross on a net of far less than that. So how are you going to address this? Because I imagine the same kind of problems will exist in other data sets of similar pricing.
Right. So I think there's a 2-part strategy here. One is overall to make the data available and with its limitations known, and we can present the caveats. And so the first one here is more of that akin to CMS's overall, not quite a data dump, but in any case, getting everything out, and people can then have the ability to understand and do with it what they will. I think as you go down this list, the bottom set, the consumer provider portals, are intended to be more focused, and I think they will address these data issues and sort of be able to really identify, okay, what we're presenting here is a clean sort of episode, and what makes sense, and it may not even be reported at the provider level, but to be able to sort of let a consumer understand what decisions they're making. And I think that we understand that and would like to use this as a way, as we learn also how to do these, to make them more refined and add the appropriate context to the presentation of data.
Diane?
Along those lines, in the process? You said the consumer and the provider portal in the fall. You're thinking they would be available?
Not these, so the next fall.
Next fall.
Next
okay,
fall.
Good.
The first two are this fall.
Okay,
but the consumer provider portals, and there's a broader stakeholder engagement plan for that. We just yesterday had an initial sort of meeting with stakeholders to sort of announce all of these activities coming and are seeking participation in these work groups, advisory groups as we're calling them for that. And over the next year, we expect to engage a consumer set and a provider set of both these sort of work groups and focus groups to inform how we develop the content and how to present it and everything else.
You're a complete mind reader. That's exactly what I was going to ask about. I mean, getting to Dr. Weinstein's comments as well, you know, it's really important to think about not only does this resonate with the target audience, whether it's the provider community or the consumer community, and how the information might be interpreted or misinterpreted, but frankly, particularly I would say with provider groups, to make sure that there's no surprises. People know it's coming, they know what's in it, that kind of thing.
Absolutely.
Other questions or comments? Thank you very much.
Thank you.
Move to agenda item number 4, which is an action item for certificate of need for Lorian Harford. Lorian Bel Air applied for a CON to add an additional 27 comprehensive care facility beds to the 21 approved by the Commission in February 2014. And the project will also increase the number of assisted living units on Lorian's Bel Air campus. Kevin McDonald will present the staff's recommendation.
Thank you. The applicant this month is Lorian Harford Incorporated, doing business as Lorian Bel Air. They are an affiliate of Lorian Health Systems and 10 facilities operated by the Lorian system. They're currently operating with 69 nursing home beds and 56 assisted living beds, and they have a certificate of need which the Commission approved in February of 2014 for 21 more beds. They've not yet begun that project, and they are here today applying for 27 more. The new application was actually triggered by an updated and corrected bed need projection that was promulgated in October of 2014. And at that point, Lorian was well into their architectural drawings, but then with this new bed need projection kind of reassessed the situation and sent us letters of intent for 2 projects because the new bed need projection was for 97 beds. They sent us 2 letters of intent, one for the 70-bed facility that you approved last month, and the other letter of intent was this project to add 27 beds to the existing approval. As a practical matter, we reviewed this project as a 48-bed addition, even though technically it would be a 27. It would be the approval of 27 additional beds. If this project is approved, staff would recommend that they are issued a CON for 48 beds to supersede the existing CON, which would then become void. The proposed project is a 55,000 square foot 3-story addition. It would add 48 nursing home beds, 34 assisted living beds. If it was approved at the end of that project, the total facility would be 117 nursing home beds and 90 assisted living. The total estimated cost of the project is a little over $13 million. 5.8 of that is the nursing home portion of the project. It would be funded with $2.5 million in cash, a $10 million mortgage, and then a little over $500,000 loan for furniture, fixtures, and equipment. And I know that the question came up in the past. In this particular application, the applicant listed the cost of CON preparation at $25,000. The key facts and background for this project, the applicant has a relatively strong track record for quality. They ranked higher than the state average on a majority of key selected quality measures. The net need, in effect, in the jurisdiction is 27 after last month's approval of 70, and the jurisdictional occupancy is currently 93%, which is among the highest in the state. Viability and financial feasibility looks strong. There's a letter of interest from Wells Fargo Bank indicating an existing relationship and an interest in financing this project, and a letter from a CPA, Michael Snarsky, who states that the investors and owners have the financial resources to fund this project. Looking at their operating projections, the applicant made reasonable assumptions on payer mix and occupancy. In fact, their projections for Medicare utilization is actually slightly lower than they are currently running. We would expect that the impact on other providers in the region would be very minimal. This is this would be about a 9% increase in supply, and as I said earlier, we have a very high occupancy in that jurisdiction now, and we do show projected bed need. Some other highlights in the report, as we talked a little bit about last month, this applicant, Lorien Belair, upon their opening in 2002, did have some difficulty meeting its MOU requirements, did not fulfill those MOU requirements in the first 3 years, and but did achieve it in 2008 after they were retroactively allowed to revise the MOU to a new level that a new chapter of the state health plan had put forth. And they have met their MOU requirements for the most recent 6 years for which data is available. So wrapping up the staff recommendation, there is a net projected need for the beds. We have a high occupancy rate, an applicant with a good track record, good quality track record, and shows expectation of financial viability. Staff does conclude that the proposed project complies with the applicable criteria and standards in the state health plan, and would recommend approval of the CON with our standard condition regarding meeting a Medicare MOU. With us today, representing the application, is the attorney of the applicant, Jim Forsyth, and CPA, Michael Snarsky.
Very good. Can I get a motion to approve the certificate of need? Second. Okay. Let's open it up for questions and comments. Good presentation. All in favor? Aye. Any opposed? CON passes. Move to agenda item number 5, which is around the state health plan of facilities and services, proposed permanent regulations for cardiac surgery and PCI services. Eileen Fleck will present staff's recommendations for changes to the cardiac service and percutaneous coronary intervention services chapter of the state health plan for facilities and services. She'll provide a summary of comments received during 2 informal comment periods, as well as staff's analysis and recommendations regarding those comments. I want to note that the Commission seeks informal public comment on draft regulations, even though the step is not required by Maryland law, and it's something that most state agencies do not do, because the Commission has learned that broad public input that it receives during the informal comment period can result into regulation improvements that are later adopted as proposed permanent regulation. Eileen?
Thank you. Good afternoon, Mr. Chair and Commissioners. Today I will be reviewing some of the comments received during the 2 informal public comment periods on draft amendments to COMAR 1024-17, the State Health Plan Chapter for Cardiac Surgery and PCI Services. However, I want to just first briefly review the history of the development of the State Health Plan Chapter. I know we have some new commissioners. So legislation was adopted in 2012 that directed the Commission to update the State Health Plan Chapter based on advice provided by a clinical advisory group composed of experts from outside the state as well as within Maryland, and clinicians and representatives from Maryland hospitals. So this clinical advisory group was chaired by a cardiac surgeon and an interventionalist, both from outside of Maryland, and its work culminated in a report with recommendations that was issued in June of 2013. So staff used those recommendations to develop an updated state health plan chapter that was effective in August of 2014. At the time that we completed those regulations, we knew that we would be coming back and amending the regulations in the near future in order to address in greater detail the standards for external review. And we also expected that there could be other minor issues that would arise as hospitals began taking steps to implement the new state health plan chapter. Fortunately, there is a standing advisory committee, which was something that we included in the updated regulations. So this advisory committee is composed of representatives from Maryland hospitals and healthcare systems and some other organizations, and it provides advice to us. It's met 3 times to discuss specific issues pertaining to the update of the state health plan chapter. So staff relied on the committee's feedback when we were drafting the amendments to the state health plan chapter that we posted in April to address the specific standards for the external peer review process, including the qualifications for the reviewers, the questions to be asked by reviewers, the process for selecting cases, the requirements for external review organizations, and other such requirements. So the comments that we received on the additional draft standards for external peer review processes included requests for clarification and minor changes that staff implemented in the subsequent draft posted. MedStar Health commented that some of the standards were too prescriptive, and it recommended that the advisory committee be consulted on revising the language. And Frederick Memorial Hospital commented that an external peer review organization that is approved by this commission should be capable of appropriately randomly selecting cases. So we do have a very detailed description of how to randomly select cases. It was the recommendation of our Cardiac Services Advisory Committee to adopt a specific process for random selection that would be followed by everyone. And we've concluded that the process is a reasonable one, and it may be accomplished with software that's commonly available to businesses such as Microsoft Excel. So we're not recommending changes in response to that comment. On the second draft posted for informal public comment, LifeBridge Health commented that the definition of procedure success, which gets used by the external reviewer in looking at cases, was not up to date with the current guidelines. And so we agree that our standards should be up to date with the current guidelines, and so we have proposed making a change there. Essentially, it's a more stringent standard in terms of the amount of stenosis that's considered acceptable, or what's the goal. Both MedStar Health and LifeBridge Health commented that the requirements for internal and external review should be streamlined, and LifeBridge Health specifically mentioned paragraphs 0.07C, 4C, and D as confusing, and noting that the former refers to external review only and the latter refers to both external and internal review. LifeBridge Health also proposed that a minimum of 5 cases or 10% of cases be reviewed rather than 10 cases or 10% of cases for the review of individual interventionalists. And the University of Maryland Medical System commented that the requirement for internal or external review of 10% of cases or 10 cases is an undue burden, whether it's conducted internally or externally. And it suggested that while internal review is less expensive, the time required is still a burden and limits the time for review of other cases where there are complications or other unusual cases. So the University of Maryland Medical System recommended that a threshold of 5% be used instead for internal review. The 10% is something that was recommended by our clinical advisory group, and so that was the basis for the recommendation. In terms of the requirements for internal and external peer review, our intent is to be consistent with those recommendations of the clinical advisory group. However, we do also want to provide some flexibility, which is why we recommended that instead of having an internal review of 10% or 10 cases for each interventionalist and a separate external review of 5% of cases, we decided to allow hospitals to have an option of combining those reviews so that they could conduct the reviews together. And in addition, as a result of feedback questioning the number of cases to review for each interventionalist, we did go back and review the final report from the Clinical Advisory Group from June 2013 and realized that it includes the recommendations for a minimum number of cases to be reviewed per physician for the external review, not just for an internal review. And so we did revise the language in the proposed chapter to include a requirement that at least 3 cases per physician be reviewed semi-annually, which would be 6 cases annually. The Clinical Advisory Group has specifically recommended 10 cases per physician for the external review annually. However, staff concluded that such a requirement would be expensive and a review of fewer cases would be sufficient because many interventionalists perform cases at 2 or more locations and some only perform a small volume of cases annually. So having 6 cases may be more than 10% of their cases at a given location. So even though it's a lower standard, I think that it's one that makes sense potentially. So this is a new change that we made rather late in the process. It's not one that was included in the draft that the public had an opportunity to comment on in June, but because it is consistent with the Clinical Advisory Group, we do think that it makes sense that this should be included. Another change that I want to mention is that staff removed the requirement for external review of STEMI cases. That's included in Regulation .06, which refers to criteria for certificates of conformance. This change effectively removes the requirement for external review of primary PCI programs, and that change was made based on feedback from our Cardiac Services Advisory Committee at the March 2015 meeting. So a majority of the members favored the change because they expected that very few of those types of cases would be deemed inappropriate. And the impetus for the external peer review requirement was really physicians performing elective PCI procedures inappropriately on patients. And so that change was included in the draft amendments to the chapter in April of this year. Dr. Julie Miller recommended that external review of primary PCI programs be maintained because in certain circumstances it may be appropriate to consider cardiac surgery for such patients. In addition, Frederick Memorial Hospital commented that primary PCI cases should be reviewed for evaluating programs and for evaluating individual physicians. Based on the consensus of our Cardiac Services Advisory Committee, though, we have not recommended changes to address those comments. Another recommended change that I want to mention is that throughout the State Health Plan chapter, staff changed references from cardiac surgery to open heart surgery. This change is consistent with a discussion of our Cardiac Services Advisory Committee that the volume standards for cardiac surgery programs should be based on open heart surgery rather than a broader list of cardiac surgery procedures. The rationale for this proposed change is that the purpose of the volume standards is for cardiac surgery programs to be of high quality and for there to be sufficient volume that we can accurately and timely assess the quality of programs. Also, the research that supports the volume standards in the State Health Plan chapter is primarily based on research related to coronary artery bypass graft surgeries specifically, and so the inclusion of other types of cardiac surgery procedures that are much newer and have a different type of technique that's used might be something that dilutes the intent of the volume standard. In response to the draft chapter posted for informal comment in June, the University of Maryland Medical System recommended that the Commission be extremely cautious about excluding cases from the volume calculations for cardiac surgery. It proposed that whenever a procedure is conducted that requires the capacity and capability to perform cardiac surgery, it should be counted in the volume requirement. Also, Dr. Jamie Brown, who's a cardiac surgeon affiliated with the University of Maryland Medical System, commented separately that he disagreed with the proposed classification system that separates open heart surgery and cardiac surgery, noting that the infrastructure required to perform safe cardiac surgery is extensive. He suggested an alternative definition of cardiac surgery and included a list of additional ICD-9 codes that fit his proposed definition. In contrast to those comments from the University of Maryland Medical System and Dr. Brown, both MedStar Health and Peninsula Regional Medical Center expressed support for the use of open heart surgery rather than the broader category of cardiac surgery when evaluating the volume standards. MedStar Health noted that it is important to count only open heart surgery cases due to the strong link between volume and quality specifically for open heart surgery. And MedStar Health also commented that setting minimum volume standards based on cardiac surgery cases would significantly reduce the number of open heart surgery cases necessary to open a new program and negatively affect the quality of care provided at sites. Commission staff worked closely with a subgroup of volunteers from the Cardiac Services Advisory Committee to evaluate the appropriate cardiac surgery codes to include for the purposes of counting volume and figuring out which codes should be restricted to hospitals with a cardiac surgery program. In many but not all cases, the volunteers agreed on how to categorize the codes. If any one of the volunteers proposed that a code should be included as cardiac surgery, the staff conducted further research and we checked how many times the code was showing up at other hospitals, and we checked with those hospitals to find out if it was an error or not, and if they had an opinion on whether or not it should be restricted to hospitals with cardiac surgery programs. In some cases, there's like an emergency situation, or it's a matter of patient care, and so there are some exceptions. I think it's not as clear cut as it would be nice, because I felt like we struggled with this a lot. So we did try to consider these codes carefully. I would say that sometimes people's opinions went back and forth a little bit, and it's a struggle. I also want to mention that with these codes, in some cases, they do encompass a range of surgical procedures, and they may be open or closed, and they may be performed by cardiac surgeons sometimes, but also non-cardiac surgeons in other cases. And so in order to most efficiently and accurately identify what should be counted for volume standards and utilization protections, we did want to stick with a definition where it was a clear cut in terms of only a cardiac surgeon is going to be doing this procedure. In addition, if we're including codes that could be performed safely by a non-cardiac surgeon, that would result in an unintentional expansion of certificate of need regulation. So we think that once the ICD-10 codes have been implemented, that the procedure codes will be reevaluated, and those codes do allow for greater discrimination among some procedures, and so we think that using those codes may address some concerns about properly accounting for cases. I would also mention that although we have narrowed the definition in terms of volume for what we're looking at with cardiac surgery, when we're looking at like a certificate of need and the financial analysis, we are going to include all cases to look at the financial analysis of a program, and so we are trying to make sure that we're logically applying this new approach that we're taking. So that really concludes my overview of the comments and the key changes that staff has proposed. At this time, I would like to ask for your approval to adopt as proposed permanent regulations a replacement COMAR 1024-17 State Health Plan for cardiac surgery and PCI services. I would also be happy to answer any questions that you have.
Can I get a motion to adopt COMAR 1024-17?
So moved.
I heard a second. Let's open it up for questions. Dr. Peralta.
Thank you so much for the report. And I have a clarification question in regards to volume, the volume standards, in particular in reference to pediatric patients. I understand the issues related to the definition of cardiac surgery versus open heart surgery, and it seems like in pediatric this is related to open heart surgery. It's not quite clear to me what codes are used, and are they different than adults for pediatric patients? So how is the volume going to be assessed there? It's not clear. And also, the age range seems to be maximum 15 when pediatric patients go beyond that, and they pretty much have the same conditions.
Right. Well, we do just have one list of cardiac surgery codes, and so that does include the pediatric procedures. So it is primarily an age division that we're using to define pediatric surgery. I know that with congenital heart problems that a lot of times, even though they're older, maybe they're 18 or 20, like the expert in their surgery is the pediatric specialist. I would say that I think right now we have 2 pediatric programs. I'm not sure if we will have a lot of interest in having another pediatric program or not. It is something where we didn't wind up spending a lot of time talking about, even with our clinical advisory group. And so essentially, we kind of decided to leave it alone. Like we didn't, the standards that are in there are the standards that existed before we updated the state health plan. Like a lot of the wording is the same. I would say, is your concern that we would, I guess, overstate who would be using an adult program? Or
the age concerned is it's an issue that adolescents are beyond 15 years of age, but they have metabolic changes and some other physiological changes that are important to take in consideration, and getting them to be operated by, for example, adult care is a very different kind of issue. So that is one of the major concerns related to age, and that's why my question about that and also the volume.
Right. Well, I mean, I'm not sure that our regulation should influence where an individual patient is treated. So, I mean, I think we're certainly not restricting. Like, I would expect that it's still the case that 20-year-old patients may be going to a pediatric cardiac surgeon if that's the appropriate surgeon for them.
So it wouldn't. These regs would not in any way limit where a individual could be treated. So I think some of the points that you raise as the appropriate clinician are important issues, but they wouldn't be governed by our regulations in any way that the individual or the individual's parents would make the decision on where the patient would be treated. So I wouldn't see this as a limiting factor in this.
So the volume.
What are maybe you can the volume requirements for pediatric?
I thought it's like 130 cases, maybe.
Lower than.
And we don't really have like a minimum standard where we would potentially shut the program down. Yeah, we have that for adult programs, but we don't have that type of standard for a pediatric program.
So if I read you right, sort of the context of the purpose of the regulations and the background was really to kind of focus more around the adult side, and so you've kind of appropriately had a light touch on that because it wasn't the intent of the reg.
Yes, I mean, I feel like there's so much to talk about in this area that it seems to take a lot of iterations and a lot of time, and we sometimes, set things aside and then we have to come back to them later. But like I said, we tried to just stick with our current approach.
Other questions or comments? Diane.
Thank you, Commissioner Canio. Just a question about timing. You mentioned ICD-10 giving the ability to be more specific in the coding. It seems to make sense to me to be more specific in terms of what you're asking for. So clarifying open heart versus other cardiac surgery. ICD-10 code timing, does that mean that we would be back revisiting these regs in a year, or what?
I think so, yes. I mean, I would say we felt like it's important to have the more specific standards for external review. Like we did want to get that put into place so that we can start doing these certificates of ongoing performance. But yes, unfortunately, we feel like, well, this is important to get done, even though we anticipate we may need to amend these a year from now.
Other comments? Not. All in favor of approving the plan? Aye. Any opposed or abstentions? It is approved.
Thank you.
Eileen, I think now we're moving to Cardiac Community Core Lab. They are requesting approval by the Commission to provide external review of percutaneous coronary intervention services. And you are going to summarize the information and ask the Commission to conditionally approve Cardiac Community Core Lab as an external review organization.
So good afternoon again. Cardiac Community Core Lab is requesting approval by the Commission to provide external review of PCI cases. As I just talked about, this is a new requirement for hospitals where they need to review 5% of their cases. The managing partners are Dennis Friedman and Michael Chen. Dr. Friedman is Director of the Cardiac Catheterization Laboratory and Medical Director of Inpatient Cardiac Surgery, Inpatient Cardiac Services at Shady Grove Adventist Hospital. And Dr. Chen is Director of the Cardiac Catheterization Lab at Washington Adventist Hospital. And he also serves as the Chair of Cardiology at Shady Grove Adventist Hospital and is the Chair of Medicine at Holy Cross Germantown Hospital. So Cardiac Community Core Lab is not currently providing external review services to Maryland hospitals. However, it has provided letters from 4 hospitals at the time that I drafted the memo, which are Shady Grove Medical Center, Washington Adventist Hospital, Holy Cross Hospital, Silver Spring, and Western Maryland Health System. Since I drafted this memo, it did provide me with another letter of support saying that Prince George's Hospital Center would also expect to use their services if they're approved by the Commission. And then also there was a letter from Frederick Memorial Hospital, which was essentially a letter of support endorsing plans for the formation of the organization. And it did, describe the organization as a viable option for its use in the future, but it did not have the kind of letter that the other hospitals included saying that they did in fact plan to use the organization. So the information submitted by Cardiac Community Core Lab suggests that it will likely meet the definition of an external review organization. That definition is that external review means an independent review by clinical experts who are not affiliated with the hospital or healthcare system associated with the cases being reviewed. An additional hospital may not have its physicians perform external review in exchange for physicians at another Maryland hospital performing its external review unless such reviews are done through a commission-approved blinded system that involves 4 or more hospitals. So essentially, this organization wants to be this blinded review system that reviews other hospitals in Maryland. And the idea is that because the information is blinded and we have lots of hospitals and they're all mixed up, that there won't be as much of an opportunity. There won't be an opportunity to have a bias against who's being reviewed, in favor or against. So even though it shouldn't be an issue, Dr. Chen, who has, as I mentioned, close affiliations with a number of these hospitals, has said that he would not review those cases in order to avoid a conflict. And it is expected, there are just 2 partners right now, but they are expecting to have other physicians who become involved. And so even though he's one of 2 people right now who would potentially review cases, he would excuse himself from the reviews of several of those hospitals, and someone else would be performing those reviews. So the Cardiac Community Core Lab has said that they will blind the information with respect to the physician operator, the hospital, and the patient, and that they'll review the cases for appropriateness using the American College of Cardiology criteria and looking at the angiographic images. The hospital will receive a review of each case submitted to the Cardiac Community Core Labs and a summary sheet detailing the overall institutional performance. Cases found to raise concerns with respect to appropriateness will, or lack of significant stenosis or deviations from standard of care, would be automatically sent to a second reviewer for another opinion, which is something that we have included in the proposed regulations as important. Cardiac Community Core Lab has stated that it will modify its process of case review as required by an update to the regulations. And so at this time we are recommending, based on the information provided, that the Commission could conditionally approve Cardiac Community Core Lab as an external review organization. And the recommended condition is that prior to initiating external review of PCI cases, Cardiac Community Core Lab shall provide information satisfactory to MHCC staff documenting its ability to perform the functions of an external review organization in compliance with adopted proposed chapter requirements for external review of PCI services, including an appropriate blinding process, executed agreements for external review with at least 4 hospitals, and documentation of the participation of a sufficient number of qualified reviewers to assure that it can accomplish the required independent review by clinical experts who are not affiliated with a hospital or healthcare system associated with the cases being reviewed. So I believe that Dr. Chen and Dr. Friedman are available to answer questions by phone. Unfortunately, they planned vacations well in advance, so they could not be here in person today. But if you have questions that you want to direct to them too, that should be fine.
I think they're on the phone right now.
Okay, so we just have Dr. Michael Chen right now.
Yeah. Hi, Doc. Thanks for having me.
Thank you. So can I get a motion first to approve, to conditionally approve Cardiac Community Core Lab as an external review organization? Motion. Second. Okay. Any questions for Eileen or Dr. Chen? Seeing none. All in favor? Aye. Any opposed or abstention? Organization is conditionally approved.
Thank you.
Agenda item number 7 is the semi-annual update from the Maryland Patient Safety Center. If you recall, in December 2014, the Commission redesignated the Maryland Patient Safety Center, designated the Maryland Patient Safety Center, Inc. as the State of Maryland Patient Safety Center. And we memorialized the designation via an MOU. And among the provisions in the MOU, MPSC committed to seek input from the Commission as it develops its strategic plans and would update the MHCC on future plans through semi-annual presentations. We have also filled a position on the board, and I'm happy to announce that Paul Fronston has been asked to serve on the board, and Robert Imhoff, who's the Executive Director of the Maryland Patient Safety Center, is here today to provide the first 6-month progress report. So welcome.
Thank you. Good afternoon. Appreciate the opportunity. Do I control the? Oh, thank you. Okay. Just go over a quick couple of things administratively. As Chairman Tanio mentioned, Paul Fronston was added to our board, as were 4 others elected for the new fiscal year for a 3-year term. They include Deborah Dokken, who is affiliated with Sibley Hospital. She is a patient family advocate. Cherie Sample Hughes is a delegate from the Maryland General Assembly representing District 37A, Wicomico County. Susan Sheridan, also a patient family advocate, a nationally known speaker in this area. And then Barbara Tchaikovsky, who is former president of Mainline Hospitals in Paoli, Pennsylvania. Barbara has retired and made the Baltimore metropolitan area her new home and has been seeking opportunities. She met with a few of our directors and she was recommended to the board. So we're delighted with the new additions. We lost 2 members through both choice and then term. Senator John Astle, who was a founding board member, has termed out after 3 consecutive 3-year terms, and then also Chris Goschel from MedStar Health has opted not to be reelected. She served 1 3-year term. So we are working with the legislature to identify a new representative from the state senate. We have 23 current members, and we have the ability to have 25 according to our bylaws. Our strategic partners remain the same as when I was here previously, but just to remind you of who they are. And then to discuss our strategic direction, overall, we are always looking for our programs to improve culture of patient safety, expand provider environment. As I also have mentioned previously, the organization was very much hospital focused. We are making every effort to include other providers. Currently, we are working hard to involve long-term care and ambulatory surgical centers. Our programming and our educational opportunities are reflecting that. We are in a rather aggressive recruitment mode and trying to involve those areas. On our board is Joe DeMattos, who's head of HFAM, we're utilizing him, and then Andrea Hyatt, who is also or involved with the ambulatory surgical centers. We are always looking for programs that support provider efforts with regard to the new waiver and the initiatives associated there, and then continued coordination with statewide healthcare providers, including the HSCRC, OHCQ, MHCC, and DHMH. We have just ended fiscal 15, June 30 of this year, and some of our highlights include we have initiated 2 pilot programs. One is our Caring for the Caregiver, which is a second victim program that we had developed by Johns Hopkins Armstrong Institute. We have successfully piloted those programs at 2 hospitals, the University of Maryland Medical Center and GBMC. Those programs have been initiated and are in full swing at those organizations. We also have initiated pilots of our certification program with Anne Arundel Medical Center, Northwest Hospital, and Levendale, representing the long-term care community. They are in various stages of the pilot program or the pilot process. We did a 1-year education program regarding OB hemorrhage and have contributed to the decrease in OB hemorrhage rates throughout the state. We established a cooperative relationship with our new QIO, which is VHQC. We are working with them as part of our recruitment efforts for the long-term care community. We are looking to establish a hand hygiene initiative with the long-term care community, and we are working with them to bring those facilities into that fold. Speaking of hand hygiene, we completed the hospital hand hygiene initiative, which began in 2010. We had 12 consecutive months at a goal of the goal was 90%. We reached that again for 12 consecutive months. The Hospital Association has taken over that initiative. They are an additional 9 months of 90+% compliance. So we're very confident that this has become hardwired into the hospitals, and they continue to perform very well. That started out at a compliance rate of 72%, and again raised that and to be able to reach that goal. We began our Improving Sepsis Survival Collaborative, which is focused on decreasing mortality associated with sepsis. The first cohort of 10 hospitals began in July of 2014. We are just reaching the anniversary of that. And cohort 2, an additional 10 hospitals, began in April 2015. That involves monthly calls, webinars, and discussion of best practices surrounding early identification and early treatment using a rapid team approach to treating sepsis. And finally, our falls rate with injury and long-term care facilities went from 19.7%, or pardon me, decreased to 19.7% from 28.3% for the period July 14 to May 2015. Our program initiatives for fiscal 16, as I mentioned, included the hand hygiene for long-term care. Once the Hospital Association has decided what their plan is for the hand hygiene initiative, if they continue, we will keep the emergency department component of this on hold. When they do suspend it, we will then start recruiting for that specific area. Our Safe from Falls in the long-term care community will continue through December of this year. Our sepsis program, as I mentioned, is into cohort 2. This is a 2-year program for both cohorts. The Caring for the Caregiver, the second victim program, is being actively marketed as a fee-for-service program. One of our charges on the administrative and financial side is to diversify our revenues. We are doing that through a number of vehicles, including programs like this, where we will receive fee-for-service. The certification program, again, the same thing. This is to remind you, an organizational patient safety certification that is aimed at improving culture of patient safety. The goals include increasing the number of reporting of near misses and decreasing the number of adverse events within hospitals. There is also application for the certification program within the long-term care community. Adverse event reporting, I am sorry to say we continue with challenges there. We have 6 organizations identified, 4 hospitals and 2 long-term care facilities that we are in the process of implementing and starting the program with them. As I mentioned when I was here previously, there is a reporting issue with the adverse event in melding the issue from different vendors into one. I have had discussions with Ben and his staff about what we can do to standardize and make that situation consistent so that all hospitals are at least reporting at least some level of similar data so that we can easily mesh that into our system and with the vendor that we have. But to date, the reporting is still all across the map, and it makes essentially impossible for us to bring other than the Quantros hospitals, who is our vendor, into that. Clean Environment is a new initiative for fiscal 16, and it is a progression of our hand hygiene initiative where we were looking to reduce hospital-acquired infections. This initiative deals with surface contamination. We are measuring 3 specific areas: C. diff, MRSA, and pardon my clinical ignorance, and VRE. We are also looking at contributing to a lower overall hospital-acquired infection rate through this program. This looks at service contamination throughout the organization, and not just hospitals, but also long-term care facility and ambulatory surgical centers. This is based on work or papers from the CDC, and we will be using a swab technique to determine the level of contamination and then how well that is abated within the organizations. We're looking at this as a 2-year program also. Our neonatal abstinence syndrome and reduction of first-time C-section programs are through our long-time partnership with DHMH. The neonatal abstinence syndrome, in keeping with the governor's initiative around substance abuse and heroin abuse, though not directly related, certainly involved within that area. We will be composing an expert panel of faculty to establish treatment protocols for neonatal abstinence syndrome. Our reduction of first-time C-sections, a very important initiative. Currently, Maryland is number 9 in overall C-sections and number 7 with NSV, nulliparous, singleton vertex, first time, 1 child in a downward position C-sections. The issue is that first-time C-sections often lead to future C-sections. We are working on partnering with ACOG on a bundle that as a toolkit to work with the birthing hospitals in Maryland to reduce that rate. We have our PSO forums, which we conduct on a monthly basis in addition to our safe tables. One of the benefits of being a federally listed patient safety organization, there are certain protections. Our safe tables allow organizations to come together in a confidential environment to discuss situations and discuss best practices and what is going on specifically in their organizations. No notes are taken. All the conversation is privileged, so people are free to speak and discuss what is going on and what works, what doesn't work in their organization. We continue with our slate of education and training programs such as FMEA, failure mode effect analysis, root cause, lean, team steps, human factors, and engineering, to name a few. And then our two conferences, our medication safety conference in the fall, and then our annual patient safety conference in the spring. With both the education and training and also the conferences, we have made a concerted effort to be more inclusive of the other provider areas and expanded the presentations and expanded our topics to include areas germane to those provider areas. Some graphic representation for you as far as our initiatives. This is the long-term care rate of falls in participating facilities. This is the rate. While we monitor this, this is not part of the initiative. We are looking at rate of falls with injury. This is the area that we look at, the rate of falls with injury. You can see starting from 28.3, as I mentioned, back in July 14, down to 19.27 in May of 15, with a decreasing trend line. Our goal is 18.99. This is data for our sepsis collaborative 1 year, or pardon me, just 11 months, 10 months, because we've eliminated the first month, which we had not everyone submitting data. For the 10 months that we had complete data, you can see kind of a flat trend line here. While we would like to see a sharp decrease in this rate, we have been told by the faculty that we are employing for this and human factors experts that 1 year is really too limited a time to really develop a trend. But for illustration purposes, I wanted to let you know where we were and what the kind of ups and downs with this that we're seeing. This is a very transparent collaborative. The information that we are collecting is not patient safety work product. We are not de-identifying data. The hospitals that are involved are seeing what other hospitals are doing in addition to the data, but also the practices that they are employing. It is a very open, transparent forum, and it seems to be working extremely well. We are not taking process measures. We are only looking at number of sepsis cases and also the mortality rate. So we're making it, from a data collection standpoint, as easy as possible for the organizations to participate. Opportunities for collaboration going forward, specifically with MHCC, include access to data and data sharing. We currently do this with HSCRC and would like to be more involved with the Commission and the data that they collect, both from a measurement standpoint and also for us to look at developing trends. And as we go forward in future years with our program review process and determining what initiatives and what programs that we put in place going forward. Also, as I just mentioned, the program review process, we would like to have an active input from the Commission on what their priorities are and what they see as important and relevant in the patient safety field, and utilize the expertise of the staff to do so. And just to have a general improved, expanded, ongoing dialogue regarding the Commission's priorities. Last but not least, to look at opportunities for joint grant funding. Thank you, and if there are any questions, I'll be glad to entertain them.
Let's open it up to questions and comments. Brent?
Thank you, Robert.
Sure.
I guess what would be helpful, the benefit of some of the new commissioners, and to remind those of us that were in fact here and have some memory issues, that it was back in December that you came before us and the Commission acted as we are legislatively mandated to do. If I'm getting this incorrect, please correct me. To designate or to deem the Maryland Patient Safety Center as Maryland's Patient Safety Center. So that's a responsibility of the Commission. that had been carried forth in the past. What changed in December was that that designation was continued. It was renewed, but it was also renewed with a new agreement. There's an agreement in place now that I believe didn't exist in the past between the Commission and Marrow and Patient Safety. That's helpful. That sets a framework for, your last slide asked for collaboration, and so we have this agreement, and the agreement sets forth a number of responsibilities both for your center and for this Commission. And I guess I go right to what I see as the fundamental of that agreement, which was there would be an opportunity for the center to come before the Commission on a semi-annual basis and report on the progress that the center has made toward defined annual goals and the timelines for those goals. So in looking at your presentation, which we appreciate, it's very difficult to understand. FY15 was FY15, but looking forward to 16, there's a long list, probably a dozen different initiatives, but I didn't see that kind of falling into a framework of a plan with a goals and a timeline.
You are correct. And Ben and I had this discussion very recently, and I must apologize. We fell short on providing you with a strategic plan and those performance goals. We got caught up in the signing of the agreement and the elongated process there. I have promised to Ben by July 31st to have that available to you all.
That being
that strategic plan with performance goals and just a strategic direction with timelines and whatnot.
So is that a document that your board would be engaged and this would be a reflection of your organization's priorities? I mean,
yes.
It should be actually kind of a real document,
yes,
rather than a paper exchange.
No, it will be, the board will be engaged in the fact that we have already set out guidelines and performance goals with them. So this document will be reflective of that, yes.
So maybe if you could go, let's just, I don't want to belabor this, but I want to understand what we can expect by the end of July, you say?
Yes.
So let's go back to the slide that has the FY15 material on it, the program initiative. There. Well, that's...
Oh, I'm sorry, this...
There. Yeah. So how will that be transformed to help us understand how we'll go from that list of a dozen or so projects that are all over the clinical and care delivery map, how would that be transformed into a strategic plan?
My plan is to list each of these initiatives with specific goals and our expectations, and then our timeline and how we expect to accomplish that.
So let me just ask one, then I'll...
Sure.
How did these 12 or so initiatives originate? You know,
we go through a fairly, I shouldn't say fairly, we go through a comprehensive program review process each year that begins around October, and we take suggestions from organizations, we take suggestions from agencies such as HSCRC, OHQC, we talk to the hospitals, we talk to long-term care, we get input from our board as far as what priorities are. We look at performance, the 65 PPCs for the state, the waiver requirements, all those sort of things go into this long list of possible initiatives that we then discuss with a subcommittee of the board, which is our strategic planning part of the board, and winnow out which ones we want to concentrate on for the year. We then take that list, that narrowed list, back to the entire board and present for their approval.
So maybe we have a commissioner now that is part of that discussion that might help carry forth some of the linkages between this commission's priority work and what you all are doing. Is that fair to say, Paul?
There is rhyme and reason to these initiatives, and the
no. You know, I say that because from a public health standpoint, there are some serious mortality issues, but there's also a lot of things that are not on that list. So that's
No,
I'm not seeing that this is
you're
coming at me as
no, you're absolutely correct.
telling.
And we start with a long, long list of of suggestions of things that we should be looking at. Unfortunately, we are restricted by both human capital and financial capital as to what we can do. Right, exactly. And I'm not using that as an excuse. It's just a matter of fact. So we take that into account, what we can do operationally, what we have the budget for, and hopefully match that as priorities with organizations. We have certain strategic measures that we look at. Are the programs innovated? Do they reduce harm? These are strategic directions established by the board. And are they based on evidence-based best practices? Also, do they improve culture of patient safety? Are they translatable to a number of different providers? We just don't want to look at things that are hospital-focused. We don't want to look at things that are just long-term care focused. We want to look at things that are applicable over as wide a stretch of the healthcare continuum as possible. So we take all those factors into consideration when we determine what we're going to do and where we're going to go.
Well, thank you. I'll defer to some other commissioners.
I think there are
If I could I just wanted to interject one thing, that in terms of the agreement, I think that the Maryland Patient Safety Center had signed the agreement at the time the commission designated the Patient Safety Center, and through a mistake on this end, we concluded very recently that actually it hadn't been transmitted, or had been anyway. And so at the end of May, we formally signed that agreement. I made the determination that the strategic plan for this meeting would be, we would get that shortly. I think if there's some sense of more board input is wanted from MHCC to the board, that will be important input to give Robert today. But my sense was that we should bring ourselves back into alignment with what the requirements were on the MOU as soon as we possibly could.
And I'll be more than delighted once that document's submitted to come back and discuss that in detail.
Keep going around. Catherine?
As I look at this, there are a number of factors, whether they're in the long-term strategic plan or not, but like your hospital-acquired infections. And there's a lot of data being collected on that by facility, by infection type, by rate. And I'm wondering about the duplication and redundancy of purposes. I mean, we have a very transparent, growing presence through the web and the development that they've done. And so I maybe, if I were a hospital, I would be very concerned about double reporting on similar items for similar outcomes. And where is the opportunity to have some convergence or use of that data in a different way? So I'm looking at the cost of data collection from the facility standpoint. I'll open it that much. In relation to what we already require facilities to collect, it is already being packaged very beautifully on a transparent web page that's becoming increasingly more consumer friendly. And then the analysis. And so I'm seeing some, maybe some different accountabilities in the reporting relationship, but I'm seeing also some duplication of effort and duplication of what the interpretation of that information is actually means to different audiences. And there, to me, there's an opportunity there to come together. And someone can correct me if they're all flowing in different directions, which is what we do. We collect lots of data, and then expensive to collect data, but also the analysis and the interpretation. So I don't know if you're experiencing that. I know that you're expanding out into a broader audience or a broader segment of healthcare in long-term care, et cetera, than maybe some of our current data collection activities are. But I just wondered if you
and duplications, if there are any. We experienced a lot of that with the hand hygiene initiative. That was a very labor-intensive effort and in some ways expensive. As you mentioned, it required, or the methodology required a secret shopper, which involved training, and then when there was turnover, there was retraining. When a secret shopper was exposed, there was a new one that was required, and then a lot of the hospitals did not or do not have, or they have less than expeditious forms of inputting the data. So we are extremely aware of that, and we're not able to dictate or regulate what the hospitals report to us. Everything, as you know, is on a volunteer basis. So we need to be very sensitive to that because we don't want to be too imposing on asking them to do yet another data collection set. They're doing it for state agencies, for the federal government. They're doing it for internal. They're doing it for the hospital association. So we try to be as aware of that as possible and not create more work than is necessary. But for instance, the Clean Environment Initiative, those are situations that the hospitals are already reporting or looking at internally. So we're hopefully not asking them to do anything additional other than just reporting that information to us.
I think that's really important because of the cost and the demand and the distraction of reporting. I think it can be very valuable, but I think there's a rich opportunity to be able to collapse a lot of your activities and maybe even narrow your list of focus and maybe use it as the work that's already being done as a communication tool of the significance of it or some other. But I think there's a strategic opportunity because hospital-acquired infections, fall, all of that to me is if you have your own data collection, that's a duplication of what we already do.
And again, with the Clean Environment, and I'll also refer to the sepsis initiative. With the Clean Environment, we're again looking at those three areas of contamination. The hospital-acquired infection rate is HSCRC data, which is already submitted. That we
and perhaps NHSN data you might use.
Yes. Correct? Yes. So we're looking at the same things that again is available and that already collecting. We're just looking at a specific initiative as far as reduction in those areas. The sepsis initiative also, we did not want to get caught up in a lot of process measures. That's why we kept the data collection to only the number of cases, again, which is something that's already documented, and to the mortality rate. So we're trying to keep it as simple and as impactful and as meaningful as possible. Oh, I'm sorry. May I interrupt you before I forget again? Something that I did not have as a program initiative, but I did want to mention to you. It is not a specific initiative, but we have established a subcommittee of the board centering or around patient family-centered care. So as you noticed on our board, we have several advocates now involved with the organization. We are setting this up with primarily patients and patient advocates so that they can be another sounding board as far as our program review process is concerned, and that our programs are patient and family-centered care. That is the core of this, and that's what we want to make sure that we always keep that as part of the equation. So this subcommittee, this group will be kind of that check and balance in that regard. We're also looking at using this. We've begun initial discussions with the Armstrong Institute as far as, and very much in the infancy, and I hope I'm not speaking too far out of school. We're talking about a statewide coalition around this with a number of different stakeholders, including the providers, payers, patient and families, and employers. So thank you for letting me interject. I'm sorry to cut you off with your question, but my memory sometimes fails me.
No worries, no worries. Yes, my name is Commissioner Stollenwerk, and I'm very deeply interested in this, not only for Maryland, but these are topics that I work on with a number of states, with hospitals and others across the country. The MOU, I appreciate Commissioner Phillips' comments about it. The piece that I'm most zeroed in on right now with your sharing the strategic plan is that sharing the plan with us allows MHCC to provide comment and give suggestions. So I realize you've got a strategic plan in place that you were describing that you developed with your board. Sharing it with us would be a great way to see where you are now. But I think, well, according to the MOU, it's also an opportunity then to get feedback and suggestions for future strategies and the way to think about it going forward. And I appreciate, for example, it would be really helpful to understand the different types of data sources that are gathered and what's used, and what is collected that's voluntarily collected directly, what is used from other sources that are currently brought in, and the use of that data to identify your high priority program initiatives. So using the data to say where is the greatest need, and also where is the greatest potential for improvement, particularly understanding the incredible success that has been achieved by different organizations around the country. Whenever, I must admit, whenever I look at a chart like the rate of falls from injury, and I see, and maybe I'm reading this wrong, you know, we're still at 19.27%. That I look at that number and I think, okay, so that means that there's 19.27% of patients in long-term care facilities that are injured while they're falling. So rather than saying, yay, you know, we've dropped it from 28 to 19, I look at the 19 and say that's still too high.
And we look at the same thing with the hand hygiene. You know, we've improved from 72 to 90%, just for argument's sake. We're still, there's 10% non-compliance, which leads to.
So the use of the data is not only for tracking and accountability, but the use of the data really can be helpful in terms of driving the strategies. And data not just within Maryland, but also understanding, again, what's been accomplished across the country. The second piece that it would be really helpful to understand when you bring the strategy back, the strategic plan back, and that is understanding that, at least on the public website, the Maryland Patient Safety Center says that the mission is to make Maryland the safest place in the country, right? But it doesn't narrow it. It doesn't say just by working with providers. It says the safest place. And if you go and understand what AHRQ is saying to the PSOs and to others around patient safety, that the role of the patient is vital in improving patient safety. And yet, I don't see a whole lot about actually engaging patients. I understand you're creating this committee that you described.
This is our first step in that direction.
Yeah, which is great. The resources on the site, though, for patients and families are URLs to other organizations. So I don't see a whole lot that's actually focused on what is the role of the patient, and also what information can be shared that's really useful for the individual patients and families. And that goes back to the comments that were made earlier about Commissioner Montgomery around transparency. That's another area that it would be wonderful to understand where the Patient Safety Institute is planning to go in terms of increasing transparency that is useful for patients and families. I understand in the MOU that there are some restrictions given the the PSO designation. So understanding what data do you collect that you cannot share because of the PSO restrictions, what data do you have access to that you can share, and what's the plan for sharing that, so that in our free market decision-making roles, you know, as individuals, patients, and families, as purchasers, businesses, people have the information that they need to understand what is happening with safety in various facilities across the state. So thank you. I realize I covered a number of things, but
I appreciate your comment. Yes, thank you.
When you bring that strategic plan back, if it's not part of the plan, I guess it's sort of a preview of, I know, things that I care deeply about that I would really want to make sure are part of the Patient Safety Institute focus.
Thank you.
Maureen.
The question about sepsis mortality rate.
Yes.
Fascinating.
Right.
Has there been any identification of what's going on?
No. Short answer is no. There's no specific reason why there was an increase. You know, there is. We can speculate there might be reporting issues. The hospitals who are involved in these cohorts are looking at things differently now. There is, you know, the whole identification issue around sepsis. And pardon me, I'm my limited clinical knowledge here. The idea of the identification of sepsis. You know, the 4 different stages of sepsis, that's involved in, you know, the number of cases and the mortality. We had one, a good example, one hospital that was involved said we don't need to do this because we don't have anyone that dies from sepsis. And the reason they had no one that dies from sepsis is because they transferred them out before they died from sepsis, so they died somewhere else from sepsis, but they had sepsis. And had they stayed, there, you know, may have been a very good probability that that was the reason for their death. So you get into those sort of anomalies. And so again, to say specifically it's one area or one situation that's causing this, no, we have not seen that. Yeah, and as we get further into, you know, beyond the 1 year and getting things on a more consistent basis, we'll be able to do that.
Maybe I'll just give some practical suggestions for the document at the end of
Sure.
July, and then maybe in terms of process, we'll try to figure out if there's a call that we could do in August to discuss it so that we're addressing that in a timely way. But I think a couple things. On the program initiatives, I think probably the group just wants to understand a little bit more context. You know, we talked about criteria for how you selected the initiatives, and it went through some type of a funnel process. I think that would be really helpful to understand how comprehensive that was. Just again, within these initiatives, are there a set of implicit priorities and focus? Are some of these more important than others? Are there very specific goals and targets around that? And then I think that the most difficult one is probably the pivot, because you've acknowledged a couple of times, hey, we're trying to be practical and work with what we have, which means it's predominantly a hospital focus, and that we want to go out and get to those aspirations. So probably having some discussion about the constraints and challenges in there. I think if you hit a couple of those, that would sort of meet what this commission is I think, definitely interested in hearing more about.
Thank you.
Just some suggestions. Other comments?
Mr. Chair, can I add one more targeted point? And I do think you wrapped up a lot of our interests very well. The conversation that you just had on mortality rates is a tricky one, and I think it will be very important for your material to be clear when you say mortality rate, what the denominator is. Because mortality rate is a vital statistic term. And so in terms of listing cause of death on a death certificate, which is what the Office of Vital Statistics, the DHMH, does, sepsis is a cause of death. So, but I don't think that it's going to rise to the death rates that you had in your participating hospital. So that's very alarming, as Commissioner Carr pointed out. That's a very alarming statistic, but I don't think you're really talking about a mortality rate. So I think rate is a ratio, numerator, denominator. So I think It's very important that you're precise with your data presentation. The previous slide to this, when you were summarizing your work in FY15 on OB hemorrhage, you said that the OB hemorrhage rate went down. Well, fortunately, OB hemorrhage mortality due to OB hemorrhage is extraordinarily rare. So from year to year, it may be 0, 1, 3, 0. So I just don't think that that's something that you may have made progress in terms of performance and adherence to protocols, but I would not assert that your efforts, either reduced or increased or had anything to do with OB hemorrhage mortality, which is published every year by DHMH. So it's just a cautionary note about the way you present data.
Thank you.
Just very brief, thank you again. In addition to the 3 points, I would like to just, gather all the points about data that we are making right now. It's just probably expand in that report on the methodology and the data analysis, because there are incredible opportunities there that all of us are kind of mentioning, especially when you're talking about targeting that 19% or 20%. If we really focus on that aspect and how to make it better, that part of the methodology and data analysis will be incredibly useful, even with the data you are already collecting in other ways. So we'll make that recommendation as point number 4 for Chair Tania.
Any other questions or comments? I'd like to thank you for coming. And
My
even
pleasure.
though we've asked a lot, we also are quite aware of all the constraints that you operate under. And
No. And we're more than happy to comply. This, is new to us, so we appreciate your patience and your suggestion. So we look forward to the submission.
So Robert has already committed to the July 31st deadline. We'll talk further, but I think the other thing that we did hear from Chairman Tanio is we'd like to have a call sometime in August at a time convenient to the commissioners. So we'll be back in touch with you to work that out.
Wonderful. Thank you.
Super. Thanks.
Thank you for your time.
Thank you. We're now into the preview section of the agenda. And we're going to start with Maryland Health Quality Reports. Over the past several months, Commission staff and its contractor, Advanta Government Services, has been preparing for the second release of the Commission's Consumer Healthcare Quality website, which is scheduled for release at the end of this month. And Teresa will highlight the enhancements to the site and discuss strategies that the Commission is going to use to grow awareness of the site.
Thank you, Mr. Chairman. With me is Eileen Witherspoon from the center, and together we will give you an overview of the enhancements that we're working on, as well as the activities toward promotion and greater awareness of the site. So what you're seeing on the screen is actually the test site that we're working from. So this is not live. I'm not going to provide a demo. I just wanted to use this as a means of just highlighting a number of the changes that are underway. And I'd like to spend at most about 10 minutes going through all of it. We do plan to release the site to go live by the end of this month. And we also will continue efforts to promote the site. And I want to make sure that you recognize that we see promoting the site and increasing awareness of the site is a priority for us. And we are trying to balance the need to keep the site current and efficient while using new data and new functionality as it becomes available. And we are looking into ways to redirect our resources to increase public awareness of the site. So let me start with the overview of the website enhancements. And there are 4 basic enhancements that I'd like to review. Could you lift it up just a little bit so they get the entire site? The first has to do with the home page. You may recall that the home page originally had the sliders or rotating pictures as a larger portion of the home page. And based on consumer feedback, we have redesigned the home page a bit to make that slider a little smaller and to introduce the 3 boxes at the bottom that really focus on actions that one can take when you come to the site. So now when you come to the site, you can see you can review consumer ratings for hospitals, health plans, and eventually we'll have long-term care facilities or nursing homes there as well. You can compare healthcare prices. Right now we have hospital prices. And you can find a hospital, a nursing home, or a physician. So you can do all of those things when you go to any of the guides, but this way, without doing any other clicking or movement, you can see this is what you can do when you hit the home page and how you can utilize the site. Again, this is a test site, and we're still playing around with the boxes, but you can see what our intent is here. The second major change is that we have added new hospital data as well as updated the data that we normally do on a quarterly basis. So we have new HCAHPS, patient ratings, hospital quality information, and we've also added new infections data. So we have updated surgical site infections for hip, knee, and CABG procedures, and we now have surgical site infections data for colon and abdominal hysterectomy cases. And we've added the flu information. We won't go through all of this, but I'm just trying to let you know where what we've done. The third major change is that we've made placed more emphasis on price transparency. So previously we had top medical conditions and charges. It's now entitled Price Transparency, and it actually provides not only just the top 25 common conditions, but it gives the viewer the option to look at all charges.
Pause there and flag ERC 720. The number of cases, I guess that's one hospital, but you can show that actually given proper presentation. There's a lot of stuff.
Great.
Absolutely.
Okay, so the functionality is still the same. We're working on adding a filter so that if a user is looking at it for a particular condition and the DRG doesn't have the title of whether it's heart or some other childbirth and it's not under vaginal delivery, you can still find that. So we're working to improve the ability to search by filtering by certain keywords. And then the third major enhancement, and I think what has taken most of our time and effort, is that we now have implemented Monarch 6.0, and I'm sorry, you have a question. Yeah.
With regard to transparency,
yes.
Yes. When I look at this, it looks to me like the amount the hospital charges per case.
Yes.
But if somehow the hospital had a choice how much we could charge per case.
Right.
And if we're going to be transparent, we ought to say hospitals don't have any choice how much they charge per case in the state of Maryland. They do. People next door tell the hospitals how much they're going to charge per case. You got to tell the consumers that so that they don't think that, that somehow this is the hospital deciding how much it's going to charge.
Okay. Well.
Am I missing something? Is it transparency? I thought we were about transparency.
Right. Well, so what on the cover on the home page where you have the sliders, one has to do with healthcare costs.
Right.
So we have a slider where you click on it and it tells you how the costs are categorized in different areas, and then there's also at the bottom a discussion of hospital rate setting in Maryland. Okay, and it doesn't get specifically at your concern, but one of the ideas, and part of this is from previous meetings, is that we can take that slider that focuses on healthcare costs and focus on the Maryland unique all-payer rate setting system. Of course, we won't use that entire that terminology, but something that gets to what you're saying. But it's something that we'll work with HSCRC on so that they're comfortable with the wording, as we did here.
I think you got to be comfortable worrying about it. They'll be comfortable with the fact that it can't be hidden from consumers because they don't. Got to be out front. The state mandated, or whatever it is.
The other thing with that is that.
Okay.
There we go.
Is that the cost could change during whatever time of year it is, right?
Yep.
So it's not, somebody goes on there and they see $10,000. They're not going to be charged $10,000. It's giving a
An
general
average
direction of where they're going. Because the costs will be all over the place as the year goes on.
Right.
But, I mean, I think that's valid to a point, but the amount of fluctuation that can occur is within a window, I think, of 5%, with HSCRC having the ability to approve up to a 10% fluctuation, but you wouldn't expect the total charge for a normal delivery to range from, say, $4,000 to $8,000.
I certainly can.
It can.
You can.
Yes, it can. For the same services, or the same, absolutely same patient, same services.
It absolutely can.
When you try and achieve cap rates for the course of a year, you have to have a lot of flexibility to adjust up and down in order to get total revenue at the end of the year under your ration cap.
Well, yeah, and I understand what your point is, but what we're trying to provide here is some general information and average, and we can also provide some information that explains some of the issues that you're speaking of. I'm sorry.
John, so are you saying that a typical customer with a similar deductible copay health plan can have a 30% variance in what they have to pay out of pocket in February versus September? And that knowledge, or no, I'm just picking two random dates.
February 15th.
Yeah, okay, so any 2 dates, but that knowledge of price variability is probably not very high in there, because I'm not seeing that knowledge in this group, and this group is pretty knowledgeable.
So I think we can prove that. I think we can see that empirically, not today, but since we have access to the discharge data set to look at by one facility or another, a particular service, and look at the variation by on a particular condition to see what it is. I mean, we don't have to speculate on this, but we can see it.
Right. But I do believe the HSCRC has a corridor within which hospitals can go.
Exactly.
Yeah. So there.
I'm not sure that's correct, because they set their budget during the year.
Right.
And they can make X number for the year. And as the year goes on, the hospital's going to adjust that budget. I've never heard of a cap.
So we have two conflicting hypotheses. Only one can be true, so we'll figure it out.
But yeah, it may be good to have HSCRC just for a short period of time to address that.
No, I think we can. Yeah, we can certainly have them in, but I think the
in terms
staff
of
can show
their policy.
I would rather have us show our commissioners what it is, rather than let someone else come in and tell you.
Full disclosure, I have been wrong once before.
Oh, that's got a good track record there.
So there's no. If I could one more.
Every day.
One way to solve this, rather than put an average rate, doesn't mean much, put a range. A range for what they charge for that diagnosis over the course of that year.
We'll take a look at that. And,
that's a suggestion.
So when we land on who's right, or what the actual approach really is, it's just facts, right? That can be described quite well, it seems, in this piece, and then perhaps a link be added to any report about the cost or the charges that make it easy for people to know how to get back to the descriptive information, so that, because you wouldn't necessarily know looking at one, that the description is somewhere else. The biggest issue is it seems to me, it's a report that can be helpful in terms of just understanding that there is differences in what those charges are from hospital to hospital, even though they are set. They still are quite different from hospital to hospital. And that is, for a lot of the public, not a commonly understood concept. I don't think anybody would go to a report like this and think that it's going to tell them exactly what their hip replacement is going to cost, because there's lots of factors that go into that. But as I see it, that's not the purpose of this report.
And I should also add, which I forgot, this is one place where we talk about rate setting, but we add pop-ups throughout. And we can add a pop-up that provides some general information about something that everyone agrees is reasonable and correct, right?
So just to the point that I think Commissioners Flagg and Commissioner Pollack were making, that with a global budget, there is going to be fluctuation as the institutions do manage to the budget. Of course, there's always the option of not managing to the budget and leaving money on the table. But clearly, I think the approach hospitals are using is to manage to the budget today, which is different than any other place in the country.
Mm-hmm.
Yeah, I think it's about transparency. That's it. The consumer understands. And maybe the consumer don't expect to go to the hospital for a bill that's going to carry costs in terms of things, wide variation costs. But that has to exist under this system. In other states where hospitals can set their own price, there doesn't need to vary costs. They can say that we're going to put out a competitive rate for our hip replacement, whatever it is. And we're going to hold that number down. But you can't do that in Maryland. And that level of transparency, the public needs to understand what kind of system.
That's right. Just how critical it is to get this question resolved. What's the reality? Because the variation between hospitals could be less significant than the same hospital from month to month. And so, yes, we should probably look at a range rather than a figure. But that range, you know, a consumer is going to want to know not only what's the best hospital for the value, but also what's the best month if I have elective hip. What's the better month to go? If they're budget managing to the budget, is it good to go early or wait? You know, and so if that's the way it's working, consumers are going to want to know that, right? Yeah, I can see we have a little calendar like red months and green months. So I'm, you know, anyway. Yeah.
Other comments?
Okay, so we have added price transparency information, as we just mentioned, and we've also implemented Monarch 6.0. So what we'd like to do is just highlight real quickly what Monarch 6.0 brings. And remember, that is free software from ARC, and we use Monarch 5.0 in the live site that you're looking at. This is the new, the test site, as I said earlier. So in addition to additional information on for hospitals, we now can also include physician information, and this is physician profile information, and it comes from CMS, and it's also on Physician Compare. We previously linked to it, but now there is an opportunity to have an interactive tool here that would allow you to type in your physician's name, and you get background information. You get the hospital affiliation, the medical school, and you can also identify your physician by looking up either the name, zip code, specialty, or practice. So that's now found under physician information. With Monarch 6.0, one can now also, under the long-term care tab, you can very quickly find a nursing home or compare nursing homes on certain quality metrics such as staffing, health inspections, and other specific quality metrics. This information is inside the long-term care guide now, but what Monarch 6.0 allows us to do is to bring it to the front so that you can quickly compare a number of nursing homes, and you can see the 5-star rating that CMS now employs for that. So that's all now provided through Monarch 6.0. I think that is the last thing that I wanted to highlight in terms of the website update. We also are looking at changing the URL, the name, so it's a .gov URL. We found from our focus group sessions that there's greater confidence in the website if it is a government website. And so remember, we are repurposing our existing website, the qmdc.org, which was for hospitals. So if we put the .gov, we're hoping that in addition to what we say on the home page, this is an official state website that will give a bit more credibility as well. To get now to our public awareness and promotion, in February we shared with you a promotion strategy that we have begun to employ, and we have reached out to a number of organizations to get links to our website, and we're also working to participate in community and forums, health fairs, those kinds of things, to put flyers together to try to get to different community-based organizations, senior centers, and the like. And we're continuing to develop and strengthen relationships with various organizations. But what we recognize is that we have to have resources allocated, a person or sort of a portion of staff's time committed to this as a job duty, because there's so much else that we're trying to do at the same time. So we're working on trying to see how we can use our existing resources to also do more in terms of outreach to the community and to the public. And we have been providing demonstrations, and we've begun to provide presentations to various organizations, and we'll continue to do so. And as soon as we finalize this website, we will send a blast email to our stakeholders and partners, hospitals, others, to try to get the word out. And we'll continue with trying to get a PSA and other opportunities to further get attention, awareness, exposure to the site. Those are the things that I wanted to cover. If you have any questions, we'd be happy to take those.
Thanks so much for the report. Is there an opportunity to do marketing through the payers? Individuals really pay attention to that and quickly gather information, and that's probably a great opportunity to advertise that.
Thank you. That's a great idea. It's on our list, and that's one of the things we need to do. The staff has also reached out to the business community. One of the staff has gone to the Baltimore Business Journal's Business Expo, I think it was last month, and was there at a table that I believe we purchased so that we could get more exposure for the site within the business community. So we are continuing to look for opportunities to increase awareness.
Anybody else? Very good.
Thank you.
Thank you very much. On to the second demonstration, and Srinivas is going to provide a demonstration of the physician workforce dashboard. Oh, let me say that again. There we go. Srinivas Sridhar is going to provide a demonstration of the physician workforce dashboard. To give everybody a little bit of context, about 3 years ago, MHCC and the Governor's Workforce Investment Board began a collaboration to collect and report information on the health practitioner workforce, because it was recognized that basic information was fairly sparse. The physician information was deeper, but even that, there was some issues around getting timely and consistent access. And so the Commission has been working very closely with GWIB over the last couple of years to really get a basic unified health provider database. And then this demo is for physicians, but can be rolled out across the workforce without major issues going forward.
Great. Thank you, Mr. Chairman. And we realize we're all that stands between you and getting out of here on a beautiful day, so we'll try to keep it brief. So as the Chairman mentioned, we had engaged in a larger health workforce study over the last couple of years, and I think one of the hallmarks of it was that it expanded beyond physicians to include a variety of other boards and professions in the state. And what you're seeing here is actually the third phase of that effort. The first two phases focused more on sort of the data collection and standardizing data and what was needed to understand workforce study and inform workforce planning. And so the last stage of that was to say, okay, now that we've gathered the best of data, how can we present it or make it available? And this was one of the agreed upon ways to do that. So there's a lot of data in the Maryland Board of Physicians licensure renewal database, which is what underlies this particular dashboard. And what we've tried to do is, as a sort of version 1, if you will, give just an overall demographics and statistics, treat it sort of like county fact sheets. We've tried to give ways to look at the Maryland overall, look at specific counties at a geographic level, and provide some filtering tools. This is built in Tableau, which is a business intelligence tool, and it is a software that we are sort of exploring to do a variety of data visualizations. And the other, we mentioned price transparency earlier, some of the other initiatives that we'll be doing are going to leverage this software, and it gives us a quick ability to provide these sort of filters and interactive data to display on our website. So here today, you're not seeing the actual website. You're seeing it within Tableau. So this is just a data display, which we would embed on our website, which we can share with you in the future. And so we want to give you a preview of this, and we continue to work with collaborators before finally publishing it. So there are 5 tabs here. The first is really focused on providing an overall sort of demographics on physicians, giving you an idea of how many who accept certain types of insurance, hours worked, overall adoption of electronic medical records. We've grouped the specialties into some priority areas for the state related to primary care and psychiatry, which were also the focus of the workforce study. We added OBGYN here, and the other is, of course, a very big bucket of all other specialists, which is a lot of folks, obviously, and healthcare setting. So you can see here on the very right where Jen is pulling this on the county, you can select different counties. So we could say Baltimore City, for example. And so it automatically adjusts to whatever is being shown in the given city. And there's a number at the top that tells you the total number of physicians available. You know, we should remember this is across all settings and all physicians, and we are going to show you one that standardizes to a supply rate as well. The next tab gives you some overall information on the physician versus population demographic information, race, gender, and age. So one thing you might notice as something to look at here is overall in the state for the gender and age distribution, you can see obviously the gender and age distribution for the population sort of coincides together, but the gender and age distribution is different. You have essentially a younger female physician population, which is as expected, same as in the national numbers and so forth. And so again here, we're able to, so if you want to do the gender and age, you can just pick another jurisdiction. So we can do Baltimore City on both, and so you'll get a different distribution, and you can see how that looks. So the idea is just to we focus really on county filters for this effort, and we can do more sort of interactions between different types of statistics in the future. The next tab looks at the total number of physicians and a distribution of the population supply. So when HRSA usually looks at this, this is sort of a number of physicians per population, 10,000. That's sort of to standardize the supply rate, so you don't sort of look at a large number and think, gosh, there's a lot of physicians, but it might be also a very urban area, so you want to standardize it in that way. And you'll see sort of the supply, you're seeing better amounts in sort of the more urban areas, and if you hover over some of the counties, you can see what Tableau offers allows us to do what they call a tooltip. So it pops up and shows you the county, the number of residents, physicians, and the ratio that we are showing here. So you can, anyone can hover in the map. If you go to the top left, I guess there's a search tool as well. So you could type in a zip code or city or whatever in this case, and it'll zoom in and do that functionality for you. So again, do you want to click the primary care we have here? We offered one other option, which is primary care, and shows you a little bit of a different distribution. And so we have not gone to the next step, which we did in the report, which was try to estimate demand and sort of say does the supply meet the demand. In the past, what HRSA did was they took what was really their 2000 national rate and set that as the standard. It was sort of like, a little under 7 per 10,000 was the primary care, standard, but that's not, that's evolved. HRSA's evolved with that. They've been doing more sophisticated demand projections. That's beyond the scope of what we can do necessarily in-house. We did have our vendor during the workforce study do microsimulation demand models and sort of come up with what is the need in a given demand in a given geographic location by county, and then match that up to the supply. So that's something that we could evolve to. I think our goal with doing this in the study is to see what is the level of interest. Are there funding sources that we can seek to go further in this area and work on that, and how does that affect access or demand for services?
Is that okay? This is great. This data comes from the licensing board, right?
Yes, it does.
And so this is showing the counties in which the licensed physician lives?
No, it shows their primary practice.
Okay, so this eliminates physicians that are not treating patients. they're licensed,
Right.
but
So-
they're researchers or they're
Thank you for
government
prompting me. I
docs.
must have, had you.
These are real docs. that are
Thank
really-
you for that little help there. Yeah. So what we did was in Maryland, there's about who are active physicians, active patient care physicians. This is how HRSA approaches it as well. So we are eliminating those who say they're practicing primarily outside the state. We put a filter on the number of hours, so they're actually engaged in patient care. So if someone said, I do purely administration or I do purely research, they're out of here. We eliminate those who say are in the federal government. If they're at NIH or a military base, they're out of here. So this is sort of who's available to the community. We do have a methods tab, just FYI, that does explain who's in and who's out and our inclusion-exclusion criteria. But that's a very important point.
Well, to that point, then this is great data because Maryland has been for years really impacted in trying to get FQHCs, which are federally designated based on medically underserved areas, trying to compete with the Midwest and other rural states because we can never make the case because we have so many licensed docs, but they're not active. You know, so that this, to the extent that it cleans that up, this is going to be a huge boon to looking at underserved parts of the state.
Absolutely, yeah.
More soon.
Yeah, we will. And sorry, just to that point also.
Oh, okay.
To that point, the primary care office at DHMH, we do provide them this data with agreement from Board of Physicians, and we do give them the subset active physician list. So now when they do their evaluations of the HPSAs and so forth, they do use this data, and we provide that to them.
Adding in that demand data would be very, very helpful because I'm looking at Talbot County where I can tell you nobody can get a primary care physician. The demand is enormous, and maybe the ratios are okay, but we have an older population, and I think that actually misrepresents some of what goes on the Eastern Shore, and greatly so.
Right. So because it's also, and especially when we look at a county level, it's sort of the geographic distances could be really so large that it may not be that in a local area analysis that this would be adequate. We sort of shied away from showing this supply number at a zip code level because we do have another map which will show you that's a zip code that just shows raw numbers, but because it's not clear how we can standardize that and what is appropriate within a zip code, or we've considered doing other things like looking at not for primary care perhaps, but hospital referral regions or primary care service areas and so forth to sort of start to think what should be the rates in those regions, and where certainly also demand becomes an issue. Because if it's really by service location, the vast majority of these folks are probably hospitals. They're not seeing. Absolutely, which is why you see, for example, Baltimore City has this, massive number of physicians, and the question is, this is an underlying question in terms of access, is if all this large number of physicians are really hospital-based, are they indeed available to the community? And so I think there's certainly more to be done here, and we hope certainly if we can identify funding sources for it that we can continue to do this work. So sorry, go ahead. Yeah.
Question about the Medicaid data. Medicaid participation rate.
Yes.
It's difficult for me to understand what that is. You've got a bunch of MAMCOs out there.
Yes.
You're participating in one MAMCO.
You qualify here. Right. So in the Board of Physicians survey, it just says, do you accept Medicaid as this, it's almost like, are you certified, within Medicaid? And you're absolutely right. And I'd say, I think we have a related question, and I think it's very stark with the MCO because they're so regionally sort of focused that you might not really be available across MCOs, but it's this notion of networks and network adequacy as a whole becomes a concern because among these physicians, the best case example is for psychiatrists, where in the state, it looks like Maryland has quite a few psychiatrists, but only about half accept private insurance, and so I think the notion of are they available, be it on an MCO network or a private network, really is a future enhancement we hope to make, and perhaps use some of our MCDB data to sort of drive what are the payments and what providers and specialties are actually rendering services. So we know that's a future enhancement.
All right, keep going.
Okay, all right. For the specialty, so this gives you an overview of sort of specialty distribution. So the top pie chart there, again, it's consistent with the early colors, but it's showing you sort of primary care there is in blue, or psychiatry, and then the purple and orange is OBGYN and others, again, a big category. So this is showing you, again, on the left side is all Maryland overall totals, and the right side is county specific, and there's a drop down again, to be able to select whichever jurisdiction one would like. And so you have a couple of other comparisons here by specialty. And in this case, we've had specialty by healthcare setting and electronic medical record use. And so you can see the breakouts that are there. So as with the others, we've tried to stick with relatively simple and clean presentations for now, and then hope that with the feedback and with growing interest, we could expand this over time. Then the last tab, this shows you data actually at a zip code level. And so maybe we want to zoom out a bit from this. The other way. I think if you click that pin, it'll. Yeah. So this shows you actually at a zip code level. And here we tried to offer a few more filters for the interested person. So this we could actually make the point that I was just mentioning. So would you please select psychiatrist? So this shows you the overall psychiatry distribution. And then if you went to accepting private insurance, and then show only yes. So it starts to eliminate quite a few in there. It's a little hard to see probably because what Tableau does is it resets your color scale. So it's now trying to show you as much as possible. So the where you would have had larger, darker number, deeper colors are now shifted. But in essence, it'll show you much less. And we've played with making this into tables versus maps and so forth. But the idea is, in essence, that you lose a lot of jurisdictions if you do that particular filter. So this is the quick overview, and we do, if you have feedback or would like us to revise this in any way, and we certainly hope to embed it on our website, we'd be happy to hear the feedback.
No questions, Catherine?
So the end user of the dashboard is?
So I think there could be
a lot.
A lot, yeah.
Yes, okay.
Yeah. So I think, we went, when we had done similar county fact sheet type things in the past, it was done oriented towards a legislative requirement that we had to report on race and ethnicity of physicians relative to populations, and we did it then. And so it was targeted partly at legislators who were interested and sort of county health officials and so forth. So it was a county-driven analysis. I mean, you could see this becoming of great use for, say, hospitals or other practice networks trying to find, where are my physicians, where are their gaps in service availability and so forth. And so there are undoubtedly a variety of potential use cases for this. And I think, again, I hate to keep coming back to resource availability, but I think based on what we can commit to this, we can pick off appropriate use cases and start developing them that way. I think a lot of potential.
A lot of use cases.
Yeah, and I think, the chairman mentioned at the beginning, I mean, I think our goal would be to expand this to other boards' data as well and other professions. And so we've been trying to work with, say, the Board of Nursing, psychology, social work, et cetera, and try to really give a clearer picture. A good example would be something like primary care, where should you be showing, physicians with perhaps advanced practice nurses and, physician assistants. So I think that's what's coming in the future as we're able to gather data and have the resources.
Terrific. Other questions? Very good. Thanks so much.
Thank you.
Ben, overview of upcoming initiatives?
So as mentioned earlier, the Commission does not have a August Commission meeting. We will expect to set up a call regarding the direction of the strategic plans for the Patient Safety Center. In September, we'll hit the ground really running. We expect to have several CONs. One will be a exceptions hearing. You've received that, some of the material already. We would also expect that CRISP, the state-designated health information exchange, will come before the Commission to present what their accomplishments and their plans for 2016. As many of you know, they have taken on a major role in the development of the new hospital model. They have committed to playing a major role in the sort of next part of the model, which is expanding and engaging consumers in their own care management. So I think they will be, what they're doing is important to this commission as we are a partner, but also the designator, and I think it's important that the commission have a good idea of what they're up to beyond establishing the pipes, if you will, for information exchange. It's gone considerably beyond that. We'll also have another presentation updating the Commission on our work with the Maryland Insurance Administration. As noted a couple months ago, one of our senior analysts has been developing a total cost of care set of metrics using our all-payer claims database, the MCDB, that will be used in rate review, and that's been showcased to the MIA, and we're about ready to go live with the with 2014 data, so it will be ready to show you that in September. I'm sure there'll be other things percolating up over the next month, and we'll keep you informed of other activities as we move forward. So look forward to talking to you all in August and seeing you in September.
Thanks, Ben. If there's no further business, I'll entertain a motion to adjourn. Second? All in favor? Meeting adjourned.